Good afternoon, and thank you for joining today's American Society of Nephrology webinar. My name is Ryan Murray, and I am ASN's Research Advocacy Specialist. And I'm joined by my colleagues David White, ASN's Policy and Advocacy Specialist, and Zach Cribbs, ASN's Government Affairs Specialist. Today, we will be discussing the recently announced Department of Health and Human Services, or HHS, Advancing American Kidney Health Initiative. The initiative is the first major overhaul of the kidney care system since the Medicare End-Stage Renal Disease Program was launched in 1973 and reflects several priorities along discovery and innovation and comprehensive-based care that ASN has been advocating for several years. We are really pleased that those priorities made it into the department's historic Advancing American Kidney Health Initiative and are excited to unpack it with you all today. The webinar is being recorded, and it, along with all today's slides, will be posted on the ASN website by the end of the week. Please hold all questions until the end. We do have time dedicated for a question and answer period. Let's begin. The next slide will help level set our conversation today on the state of kidney health in the U.S. There are clear opportunities for drastic improvement in the state of kidney care in the U.S. I'm just going to highlight that kidney diseases were the 9th leading cause of death in 2017. Approximately 37 million Americans have chronic kidney disease, or CKD, and more than 100,000 Americans begin dialysis each year, and nearly 60% of those will die within the first 5 years of treatment. In addition to these poor patient outcomes, there is tremendous financial cost associated with kidney care. In 2016, Medicare spent approximately $114 billion for people with kidney diseases. For context, that represents more than $1 in $5 spent by the traditional Medicare program. Not surprisingly, because of these statistics highlighting a poor quality of life for patients that is inconsistent with the financial cost of the treatment, the administration has made improving kidney care a priority. The White House and HHS have begun to demand that we, as a nation, pay for kidney health instead of kidney sickness. The administration sought out ways to achieve this goal through executive actions. The first action was the Executive Order on Advancing American Kidney Health, which has three major goals. Reduce the risk of kidney failure, specifically by reducing the number of Americans developing kidney failure by 25% by 2030. Improve access to and quality of person-centered treatment options by ensuring that 80% of new, and I want to stress new, kidney failure patients in 2025 are either receiving dialysis at home or receiving a transplant. And finally, the administration wants to double the number of kidneys available for transplant by 2030. This slide is an infographic that covers the goals of the initiative and the 5 new models proposed by CMS and is being provided so that you can circulate it amongst your colleagues. Again, this and all slides will be made available online at the ASN website by the end of the week. We're now going to focus on the initiative's first goal to reduce the risk of kidney failure. Here are the objectives that HHS has identified for the initiative's first goal. On the next 2 slides, we'll go into more detail about how the initiative plans to accomplish these objectives. Here, we list a few past and ongoing initiatives to improve the identification of CKD and help reduce the risk of kidney failure. The first program is the Centers for Disease Control and Prevention, CKD, surveillance system. This system was designed to document the burden of CKD and its risk factors in the U.S. population and track the progress of efforts to prevent, detect, and manage CKD. The next few initiatives are housed within NIH. The first is NIH's efforts to develop and validate a pragmatic electronic phenotype for CKD. The NIH's assembled work group presented their findings at ASN Kidney Week 2018, and a manuscript is in press with the Clinical Journal of the American Society of Nephrology and should be available soon. Their presented poster concluded that individuals with CKD cannot be accurately identified from electronic health records, or EHRs, using diagnosis codes alone, and that the workgroup's electronic phenotype provides a pragmatic and highly accurate method for EHR-based identification of patients likely to have CKD. The initiative also noted several groundbreaking NIH-funded studies on the topic, and I'll just highlight 2 that are ongoing. The Kidney Precision Medicine Project, or KPMP, which seeks to discover the root causes of kidney diseases by obtaining and analyzing kidney biopsies to identify new biomarkers, disease subgroups, molecular targets, and hopefully lead to the new development of drugs. And the Preventing Early Renal Loss and Diabetes study, which is testing whether medication can slow progression of kidney disease in people with type 1 diabetes and early diabetic kidney disease. Here are a few future HHS initiatives to improve the identification of CKD and therefore reduce the risk of kidney failure. The first is CDC's CKD initiative, which supports efforts to raise awareness of CKD, promote prevention and control of risk factors for CKD, and improve early diagnosis and treatment among people living with kidney disease. The second is the CDC's collaborative effort with the Uniformed Services University of the Health Sciences, which aim to describe the epidemiology of kidney disease among the active duty and non-active duty populations and assess their risk factors for developing kidney disease. Because the project includes non-active duty persons, these findings will have implications beyond military personnel. Now we are moving on to Goal 1's second objective. So here are a few examples of past and ongoing HHS initiatives that encourage the adoption of interventions. First, the Special Diabetes Program for Indians represents an important part of a broader approach to providing team-based care and care management. Since its implementation, the incidence of diabetes-related kidney failure among American Indian and Alaskan Native populations decreased by over 40% between 2000 and 2015. The CDC's National Diabetes Prevention Program is working to build a nationwide delivery system for a 12-month lifestyle change program proven to prevent or delay onset of diabetes. Next is the National Institute of Diabetes and Kidney Diseases work to raise awareness about screening for individuals at risk for kidney disease, education of individuals about how to manage their disease, and providing information, training, and tools that help healthcare providers. Final ongoing initiative is the Medicare Diabetes Prevention Program expanded model, which is a structured-based behavior change intervention that aims to prevent the onset of type 2 diabetes. More information can be found at innovation.cms.gov. Here are a few future HHS initiatives that will support the second objective of Goal 1. Later this year, the CDC will update its hypertension control change package for clinicians to include tools and resources to support CKD screening and early diagnosis among persons with hypertension. The second is the ICD-PISA study, a recently funded NIH study testing whether computer-generated reminders working in tandem with clinicians can reduce hospitalizations in patients with coexisting CKD, diabetes, and hypertension, and improve use of innovative and proven interventions. The final bullet is EXA Health. Under HHS, the Office of the Assistant Secretary for Planning and Evaluation is partnering with the Department of Energy to develop artificial intelligence tools for studying complex biological functions to develop new and more effective medical interventions. These interventions will focus on acute onset of disease during pandemics and man-made disasters, as well as chronic diseases, including patients at risk for progression towards CKD and ESRD.
Hi, this is David White, the Policy and Advocacy Specialist at the American Society of Nephrology in the Policy Department. We're going to begin now with Goal 2, as it was laid out. So Goal 2 was to improve access to and quality of person-centered treatment options. So this is quality and access. It has two objectives. One is to improve care coordination, and the other one is to introduce new value-based kidney disease payment models. In the past, HHS has focused on several different aspects of how to deal with kidney disease. One has been the creation of the U.S. Renal Data System and its Atlas, which has produced significant results in terms of determining what factors are most impactful for kidney patients. They are expecting that their next start will be a detailed investigation of causes of early mortality among patients who start hemodialysis, as well as expanded exploration of data sets over the Medicare data to support additional analysis. They also have been working in the Making Dialysis Safer for Patients coalition within CDC, which tries to coordinate a large number of organizations and individuals to implement evidence-based interventions and work as well with the Nephrologists Transforming Dialysis Safety, NTDS, which is also a program between ASN and the CDC. They've also talked about the Empower program, and that comes from the Office of the Assistant Secretary for Preparedness and Response, also, as you see here, ASPR, and CMS, and they have formed a collaborative to be able to make sure that dialysis services and all of the needs that are associated with that are met during national emergencies, particularly when electricity-dependent medical equipment and other healthcare services are interrupted. So these are some of the foundations upon which the administration plans to build. In order to get to the next one, introduce new value-based kidney disease payment models, the administration has already begun and laid out one mandatory model, which is in a proposed rule at the moment, and then 4 voluntary models. And those 4 voluntary models will be released in mid-August in 2019. We're going to go primarily over the mandatory model today, but before we go on, I'll just say in the voluntary model, the Kidney Care First model is the specifically nephrologist only. There needs to be nephrologists and transplant groups and others in all of the other models, but Kidney Care First is specifically nephrologists, and it will include a monthly capitated payment for CKD, and also it will include a 3-year bonus payment attributed for transplant patients. And then the next set of those is going to be your comprehensive kidney care contracting models, and those are the ones you see in the slide: graduated, professional, and global. And those take different risk levels, the first one being a one-sided risk model, the second one being a 50% risk model, and the third, the global, being a 100% risk model. So for the moment, we're going to move on now to the mandatory model, which is currently out. In the 5 models that are laid out, in each one, you're going to have ESRD facilities, and you're going to have managing clinicians who are billing the monthly capitated payment, and that have been for which the kidney patient has been attributed. The KCF model will be one that you can join if you're in the mandatory model or one of the CKCC models. So you have an option if you were included in the mandatory model to join either one of the other 4 voluntary models. If you are assigned to be in the mandatory model, the ETC model, then you could still participate in one of the other 4 models. And the system is somewhat designed for you to consider doing just that. Within the mandatory model, which is going to be the ESRD treatment choices model, the ETC model, what they have planned to do is select 50% of the country, basically. And that 50% of the country is hopefully also going to represent 50% of the ESRD patients in the United States. And it will be in managing clinicians and the ESRD facilities in selected areas. The selected area, the geographic area in this case, is going to be the hospital referral regions selected by CMS. Hospital referral regions have generally not been used in models in the past, so this is a little bit of a step in a different direction. There are 306 hospital referral regions in the United States. CMS will be randomly selecting from those in all 50 states and the District of Columbia, not from the territories, however. Now, their intention is to capture, as I said, 50% of the adult population, and they want to have an equal comparison group in this model as well. The HRRs are derived from referral patterns to hospitals, as you can see there. Okay, the ETC model payment adjustment period. That is going to be the payment adjustment period that under which most all of these projects will operate on. The voluntary models will operate from 2020 to the end of 2022. The ETC model here in this case will run from beginning July 1, 2021 through June 30th, 2026, the program beginning in 2020, but those will be the payment adjustment periods. And it will affect rates of home dialysis utilization and rates of kidney and kidney pancreas transplantation. Now, I'm going to go through the remainder of these details fairly quickly. We do encourage you to read the proposed rule. There's a great deal here that we do not have time today to go through. So as you hear this, just keep in mind that you do need to go back and address that, and you can also send us other questions to ASN Policy. So the ETC payment adjustments, they come in 2 particular forms. One is the home dialysis payment adjustment, and that's just as it sounds. It is the one that refers to your rates of home dialysis, and that is going to be a positive payment adjustment for the first 3 years of the model. And the second one is the performance payment adjustment, and that is going to be either a positive or a negative payment adjustment. And this particular part, the PPA, will increase in its weight over time, while the first one, the HDPA, will decline and actually be eliminated after 3 years. So this will increase, and this one will be on dialysis and dialysis-related claims, both home and in-center. And they will occur within what is considered the measurement year. And there's a lot said in the proposed rule about the measurement year. I also encourage you to read those sections. So the home dialysis payment adjustment, which lasts for the first 3 years, this is the one that is all upward and will be positive. So you can see here that you have a 3% upward adjustment in year 1, 2% upward adjustment in year 2, down to 1% adjustment in year 3. At that time, the PPA will be kicking in and it will be growing in its size. So as I said, the PPA will be increasing and become a more significant part of nephrology payment as the model goes along. And that will be either an upward or a downward performance adjusted on your NCP codes billed by managed clinicians. I'm mostly focusing right here on managing clinicians. There's a great deal in there about how ESRD facilities will be rated. I encourage you to read that, but for the moment, we're going to focus on the nephrologist part. You can see in this chart on the bottom right-hand corner, this is table 12 from the proposed rule. You can see that the measurement years it's a slightly complicated formula, and there are periods of overlap. So we show you this to point out that we recommend that you spend some time looking at that in the proposed rule and looking for other materials as we publish them, so that you get an idea of kind of what year in particular you're going to be adjusted for and when. And that, of course, again, is based on rates of home dialysis utilization and rates of transplantation. Okay, as in most cases, there is a low volume threshold exclusion for the PPA. And let's start out with the managing clinicians. For the managing clinicians, what CMS is going to do, or at least it's proposed to do at this point, is it's going to include those who fall in the bottom 5%. That will be where they determine the low volume threshold, which is a little different from what we've seen in the quality payment program, where there's an actual numerical cutoff. In this case, in the ESRD facilities, they're going to look for 11 attributed beneficiary years, which basically means that you need to have at least 132 of these beneficiary months to calculate to be 11 attributed beneficiary years. So that gives you some idea of what a facility will be looking for to be able to be included or to be excluded for a facility in this program. There is a risk adjustment, and it is based off of those of you on the call who are probably familiar with last year. The CMS did provide the percentage of probable patients waitlisted metric from the ESRD QIP program, and that they're going to use the same methodology that is used there. There are a couple particular points there that will provide exclusion. This is not all of them, but individuals 75 years or older are excluded. Individuals in a skilled nursing facility are excluded, and individuals who choose hospice, of course, are also excluded. There are some other factors in there, and that they're all listed within the proposed rule, but those are the main ones that will concern people.
Hi, my name is Zach Cribbs. I'm a government affairs specialist at the American Society of Nephrology. So picking up at the second goal, too, of improving access to and quality of person-centered treatment options, the third objective to achieve this goal is really to catalyze the development of innovative therapies, including wearable or implantable artificial kidneys, with funding from government, philanthropic, and private entities through KidneyX, and through coordinating regulatory and payment policies to incentivize innovation and product development. So there are a couple pieces to this goal, many of which are currently in work at HHS, and a couple of which are slated for future initialization. So the first method for improving product development is catalyzing rapid product development through public-private partnerships, particularly through KidneyX. A second method for achieving this is creating clear and forward-looking guidelines for marketing approval for emerging technologies. Third, prioritizing the development of an artificial kidney through KidneyX in their redesigned dialysis phase 3 of the competition. If you can remember, the Phase 1 winners of Kidney X were announced earlier this year. Phase 2 is currently in the works for Kidney X, and Phase 3 will really focus on the development of this artificial kidney. And third, or finally, providing next-generation organ preservation devices and systems. So for the third goal of this Advancing American Kidney Health Initiative is to increase access to kidney transplants. There's two objectives for achieving this. The first is increasing utilization of available organs from deceased donors. This is both by increasing organ recovery and also by reducing the organ discard rate. The second objective is to increase the number of living donors by removing disincentives to donation and ensuring appropriate financial support for these living donors. Future initiatives to improve deceased donation include revising guidelines to reducing the risk of HIV, HBV, and HCV transmission while preserving high-quality organs. Another method for achieving this is organizing a workshop to discuss the use of HCV-positive donor organs in recipients who do not have HCV. There's been a lot of promising research in this area, and HHS is looking to see how this might be utilized in a way that it ensures the best outcomes for patients. Third, testing accelerated placement of kidneys at high risk for discard. I think there's a large opportunity in this area in particular for increasing the number of kidneys that are utilized. And finally, reviewing the OPO conditions for coverage and proposing changes to the standards used to evaluate OPOs being organ procurement organizations. Some future initiatives to improve living donation. There are really three main initiatives outlined in the Advancing American Kidney Health Initiative. First is expanding reimbursement of travel and other expenses related to living organ donation. Currently, the federal government does reimburse some travel for living donors to be able to enable organ donation. The government is looking at expanding the amount of reimbursement by lowering the income threshold for living donors to be reimbursed. Second, considering providing reimbursement for lost wages for donors. This is currently under a pilot study at HRSA, and this executive order is looking at expanding reimbursement for living donors beyond just lost wages. And third, using findings from two HRSA studies to inform these decisions. I think I mentioned this in the previous goal. There are ongoing pilot studies looking at ways that reimbursing lost wages will helpfully increase living donation. And I think it's important that the evidence generated by these studies is utilized to ensure that we're putting forth best practices. That concludes this presentation. I'd now like to move to question and answers. We do have a number of questions on the line, and I would encourage anybody who has to write in. The American Society of Nephrology will be publishing a series of pieces in Kidney News Online related to this webinar and other questions that the public has about this initiative. So please do not hesitate to reach out to us during this webinar at any time, and we will be sure to do our best to answer your questions. So one question from the audience. Could you please address the level of funding that is committed at this point and for what period of time to help ensure the success of this initiative?
So the executive order and HHS's Advancing American Kidney Health Initiative does not include new levels of funding or funding sources, as they both fall under actions taken by the executive branch. The legislative branch or Congress controls the funding levels for federal programs through its appropriation process. The executive order and the Advancing American Kidney Health Initiative does lay out the administration's strategy and indicates that these programs are priorities for the administration. We expect that when the Office of Management and Budget drafts the President's proposed budget for fiscal year 2021 next spring, which Congress does consider during the appropriations process, it will ask for increased funding to achieve these goals laid out in both the executive order as well as the Advancing American Kidney Health Initiative.
Thank you. What is ASN's stance on the executive order and the Advancing American Kidney Health Initiative?
So again, the executive order and the Advancing American Kidney Health Initiative features priorities centered around discovery and innovation and comprehensive-based care that ASN has been advocating for several years. We are thrilled that many of these priorities, including KidneyX, again, ASN's public-private partnership with HHS, has made it into the executive order as well as the Advancing American Kidney Health Initiative.
Thank you. Could you give an estimate of what the bottom 5% of clinician practices would look like? How many patients under management would be excluded from this TPA system?
It's going to be a little bit difficult to determine that at this stage before we see how the randomized selection of HRR sections is being done in terms of what it will pick up. But we do know that within the proposed rule, what CMS has suggested is that they would take the individuals who are reporting clinicians and they would elevate their numbers up into the aggregated of the whole practice. And therefore, they're going to try to see if they can make sure that they're not penalizing, like, for example, one nephrologist who doesn't do home dialysis while they're in a practice where two other nephrologists, let's say, do focus on that in particular. So they are going to try to adjust for that. Since they are trying to adjust for 50% of the ESRD population, the 5% at the bottom tier of that should be fairly representational and in terms of what the entire body of patients covered. But that, having been said, is something that we will have to look at further, and we are trying to get a firm grip on exactly what that'll be like. It'll be something we will know more as when we release the randomized selection of HRRs. This is going to be a process that needs to be, you're going to need to follow a little bit with us because there are various details that are still yet to be unveiled.
The Phase 2 KidneyX contest will award only 3 grants, each in the amount of $500,000 each. This won't cover very many new ideas for improving or replacing hemodialysis for ESRD therapy. Will KidneyX receive more funding in order to give more grants?
Yes. So KidneyX is envisioned to run as a series of prize competitions. Redesigned dialysis Phase 1, 2, and 3 is just one prize competition. KidneyX will expand into other prizes as well as other topic areas, including drugs and moving more upstream to include prevention and detection. ASN has committed the first $25 million to KidneyX and is actively looking for external private partners to contribute to this public-private partnership. As a public-private partnership, some of the funding does come from the public sector. HHS did contribute to the first redesigned dialysis Phase 1 awards. And again, they were able to find that funding through discretionary funds as, again, Congress really does control what is appropriated to federal programs. So the House of Representatives appropriated $10 million for KidneyX this spring. The Senate appropriation process is still ongoing, and ASN is actively advocating for KidneyX in the Senate. Once the Senate finalizes their appropriations, both the House and Senate will need to come together and reconcile any differences in their appropriations. We do expect KidneyX to be viewed favorably in the Senate appropriation process, so we are expecting new funding from the government next year.
Thank you. I've got another question here. How will PT be assigned, by a practice IT or per individual nephrologist?
Well, that will depend primarily on whether you're a sole practitioner nephrologist or whether you belong to a practice. For the most part, within the HRRs, I think that they will be looking, and I said double check on this, but it seems to be that they are going to pick up the taxpayer identification number, the 10, to be able to select practices to be able to be participated in. And that's also how they will aggregate as they look at measurements. However, if you are a sole practitioner, then you would be picked up by your NPI.
Another question. I'm interested in providing feedback on the CMMI models. How would I do so?
Well, first of all, the American Society of Nephrology has multiple standing committees that deal with various policy issues. In this case, the quality committee, is reviewing everything that has been proposed here, as well as the policy committee for ASN. And they will be providing a comment letter on behalf of ASN and approved by the ASN Council and President on all aspects of this that we think are relevant, that we need to be commenting on and making recommendations for, or also sometimes we're just asking for clarification. And so at that point, we will be doing that, and that will be due September 16th by close of business. The government has a very hard deadline. So you're able to do a couple things here. First of all, you're always welcome to email the ASN policy team and provide comments of things that you would like to have addressed. That could be something that you're favorable of, or you're not favorable of, or you'd like clarification, or you have a particular concern. And there's some things that we definitely want clarification on, and we're going to be asking them to be more specific about. But you can also do that through all the channels that are available to you. In terms of the community discussions, I think this is a very good place for ASN members to be able to ask questions of one another and to make statements about what it is they may have a concern. We will be monitoring those. We'll also be monitoring social media and any of the other channels. We will be writing about this regularly in a series in Kidney News Online, as we said. And at the end of the day, you are always welcome. Everyone is always welcome to go online with the Federal Registry and by the September 16th deadline, provide any comments directly to CMS that you would like to provide. But the more that you could participate in group discussions with ASN in communities and other areas, I think the more likely it will be for us to kind of identify what are all the issues of concern or just points that they would like to have raised, and we can develop a more robust communication with CMS over this.
Thank you, David. Another question. There's been some very promising research in the space of xenotransplantation. Is the administration's efforts to increase therapies available to patients going to involve xenotransplantation as a way to increase the amount of available kidneys?
That's a great question. We definitely think xenotransplantation is an exciting and emerging field. We expect xenotransplantation as well as other forms of artificial kidney ideas to be submitted to KidneyX in the redesigned dialysis phase 2 competition, again, currently ongoing, as well as phase 3, which will launch in 2020 and will definitely advance us closer to developing a full artificial kidney. And we definitely, again, agree that xenotransplantation could increase the supply of donor kidneys.
Thank you. Another audience question. Will any of the care models be differentiating the home dialysis analysis into PD and HD, peritoneal dialysis and hemodialysis?
The way in which these proposals are being put together is that peritoneal dialysis and home hemodialysis are being put together in the category of home dialysis. They are assuming that peritoneal dialysis, they are making an assumption, will almost never be done in a facility. There may be a few exceptions to that, but for the most part, they don't believe in claims that they really ever see peritoneal dialysis in facilities. So they are going to be home dialysis categories. It's going to be a general category. It can be home dialysis with the hemodialysis, or it can be home dialysis with peritoneal dialysis. Either way, those are both considered part of the objectives that they would like to see increase in home dialysis, along with transplantation. So you're going to be judged as a nephrologist. You're going to be evaluated on the amount of home dialysis you have, and not the particular modality of home dialysis.
Thank you, David. Another question here. I'm pleased to see the administration is placing a large emphasis on prevention and delay of progression of kidney diseases. What are the primary new strategies the administration is hoping to utilize to achieve these goals?
So we are similarly thrilled that the administration is moving more upstream in terms of care by focusing on diagnosis, prevention, and delaying progression to kidney failure. The administration seeks to prevent or delay the progression to kidney failure in multiple ways, including, but it's certainly not limited to, the CDC CKD initiative, which seeks to improve identification of CKD and therefore reduce the risk of kidney failure by providing the opportunity to slow or delay progression, as well as through various NIH-funded studies, including the new PEARL study, which addresses the topic of delaying progression through medication. I would encourage you to read the entire Advancing American Kidney Health report, which can be found on the ASN website for more specific examples. But we think it's great that there is a focus more upstream and focus on prevention and delaying the progression of kidney failure.
Thank you, Ryan. I'll add to that. There are a couple other ways in which which HHS is looking at this. First of all, in the executive order itself, Section 3, you can review. They announced the awareness initiative on kidney and related diseases. This is basically part of the public awareness campaign that they would like to see done, and that they have given HHS, the White House has given HHS 120 days in order to come back with a recommendation of how they intend to implement this initiative. And that is important because, as we all know, if you don't detect kidney disease in an individual earlier on, it's hard to treat them for it. So the idea is to increase public awareness, to increase the visibility and the discussion among primary physicians and also among nephrologists and with patients. Secondly, the financial incentives have not really been placed in the system for very much for going upstream. This is a development in these payment models in which they're going to try to place focus on providing payments in the particularly in the kidney care first model to cover CKD care with a type of MCP payment to the nephrologist to be able to use to try to slow the progression of the disease and also to provide education so that there's more of a chance for the individual to be able to choose whichever modality that they would like to choose. So there's many different ways in which they are approaching that particular issue.
Thank you, David. Got a quick question here. Are people who donate a kidney going to be paid for their kidney? So this is somewhat of a tricky question. No living donors or deceased donors will be reimbursed for the kidney themselves. The only proposals that have been put forth so far are to reimburse costs incurred during the act of living donation itself. So travel expenses being the one that are primarily reimbursed now, and HHS is exploring other reimbursements such as for lost wages, childcare, or again, other expenses that one incurs during donation surgery. So no organs will be paid, nobody will be paid for their organs.
And thank you, Zach. I'll add to that. There has been a public notice that in the near future, in this fall, that there will be a proposed rule coming out for consideration that will address some of the living donation issues that Zach just referred to, and of course that would not include paying for the kidney, but would have to do with the other parts of the equation, such as lost wages and so forth. So that is something that we are looking forward to seeing when that comes out, and everyone should keep their eyes open for that proposed rule.
Are pediatric patients included in any of the care models proposed by CMMI?
So at this time, the care models proposed by CMMI do not include any pediatric patients.
Thank you, Ryan. So a question from a nephrologist practicing in a primarily rural setting. They're wondering if the Advancing American Kidney Health executive order will be doing something to approval for home care services for chronic home dialysis patients, and if there will be a pathway for more long-term nursing home residents to pursue home dialysis modalities such as peritoneal dialysis and hemodialysis at the skilled nursing facility.
Well, for one thing, we do see that in terms of some of the exceptions that individuals who are in skilled nursing facilities are probably not going to be covered in the beginning. But as they've developed the other models, they clearly would like to make sure that there's as much support as there can be, both in the financial side and the regulatory side, for providing additional care and support for practices trying to take care of kidney patients at home, but that is all still probably in the process of being developed.
So again, thank you for joining today's American Society of Nephrology webinar on the recently announced Advancing American Kidney Health Initiative. It seems we've run out of time this afternoon. If we weren't able to answer your questions, please be sure to visit Kidney News online. As Zach noted, we will be running a new series in the starting next week, over the next several weeks. We will be addressing any questions that we received here. As well, you can always email us at policy@asn-online.org, and we'll be sure to follow up and again include your question in the series of articles that we've posted on Kidney News online. Again, thank you, and this concludes our webinar.